welcome all the attendees. Thank you for joining in advance. We will start this webinar sharp at 5 p.m. I'll request all of you to stay there till that time. Thank you so much. All of you, and request you to be there. We will start this webinar within a couple of minutes. We're just waiting for a few more attendees to join. Please be there. Thank you. Good evening, all. I'm Abasaheb Kale. On behalf of Marsh India, I welcome all of you to this important webinar, Emerging Risks, Transiting from Hospitality to COVID-19 Care Centers. Today, local governments are looking at hospitality sector very in a sort of a demanding way to take control of the current pandemic situation, as well as to help them for hosting various stakeholders who are getting affected. Today, we have a very detailed agenda for this particular discussion, wherein we have some of our overseas experts to help us to understand hotel to COVID-19 care center conversion considerations. Then we will have discussion about risk assessment and hierarchy of controls, followed by discussion on managing changes in infrastructure for such makeshift transitions. We have panel of esteemed speakers from different stakeholders from this particular industry, and we'll have around half an hour discussion at the end of this particular session. Going ahead, I have few requests for all of you. To ask questions, please use Q&A option in the Zoom app. If you want to speak during Q&A session, use raise hand option in the participants window. Please refrain from using chat to ask questions or discuss any other matters. Please wait for your question to be announced. Do not repeat the question again. We have some polling questions for you. So please participate and wait when polling is live. Today we have a very knowledgeable and rich experienced panelists and speakers. We have Aditya Lingampalli from Oliver Wyman and Scott Boland-Krause. He's again from our Oliver Wyman USA team. Andrew Snedden, Senior Vice President from Consulting Solutions from USA. And Greg Rodway is from Workforce Strategies Practice, again from Consulting Solutions USA. Myself, Abasaheb Kale, I'm working for Consulting Solutions here in local office of Marsh India. And with me is Nitin Desai, who is Vice President for Consulting Solutions and Senior Consultant here. We have a very interesting panelist today. We have Mr. Harsh Thapar, who is Vice President of HKS India Design Consulting Private Limited. Sharad Garud, Deputy Head Engineering, Sir H.N. Reliance Foundation Hospital. Mr. Purnabodh Kashyap, Director, Fire Protection and Life Safety, Asia Pacific for Marriott International. And Nikhil Kakar, Senior Vice President and Practice Leader, for Consulting Solutions of Marsh India. I welcome all of our today's speakers and panelists, and would like to start with a very simple question for all of you. Radhi, can we have a question? How everyone is feeling today? Calm, anxious, or stressed? Thank you. I think more than 60% people are calm and anxious, and it's really interesting to know that around 36% are stressed. And it's quite obvious because of the situation today we are facing. Going forward, I will first introduce our first set of speakers today, Mr. Scott Boland-Krause. Scott is a principal at Oliver Wyman in their transportation and service practice. With over 16 years of experience, Scott focuses on the hospitality and aviation sectors. He has worked with clients on 3 continents and across various areas such as commercial and operations support. With him, we have Aditya Lingampalli. Aditya is a principal in Oliver Wyman's health and life science practice based out of Chicago. He has over a decade of experience consulting with healthcare providers, payers, retailers, innovators, and financiers on various strategic initiatives, including growth strategies, digital transformation, cost reduction, operating model improvements, and due diligences. His insights have been published in Harvard Business Review and the Oliver Wyman Health Innovation Journal. I hand over this session to Scott to discuss about hotel to COVID-19 care center conversion considerations. Over to you, Scott.
Hi, thank you very much. So if we move to the first slide, why should you consider housing healthcare professionals and patients? If we think about COVID-19, there's the initial outbreak where you have closure of businesses, widespread remote stay-at-home orders, border closures, and travel restrictions. But as we're seeing, in India, which is in its first wave, you will see a large spikes in COVID-19. However, there is, after that, the long haul of suppression, as what we're calling it, where we'll have cycles of relaxation and tightening of economies and ramping up of testing as well. But what this means is there will be gradual reopenings of businesses, continued work remote, but then you're going to have quarantines of confirmed cases. And as we're seeing here in the US right now, kind of a second closure, if you will, of certain parts of the states. So we're in this for the long haul. And what this means is that this opportunity to house healthcare professionals and patients is not just something here in the first wave of COVID-19, but will be here for 12 months plus as a vaccine is starting to be developed. If we move on to the next slide, we've developed a hotel and hospital COVID-19 response playbook, which looks at hotel properties, alternative uses. And we have 3 use cases, which we'll talk through today. And there's more details as well in the COVID-19 playbook. The first is housing crisis responders. So housing guests primarily in terms of visiting volunteers, healthcare professionals, emergency service providers as well. There's 2 clinical use cases as well that we outline in the playbook. The first is care for non-critical, non-COVID-19 patients. These are patients who require medical professional oversight, but do not require isolation. The second of the clinical use cases is care for COVID-19 patients with mild symptoms. So you can think about these outside of ICU facilities. Guest patients require isolation and medical oversight. And we'll talk a bit more about what that means in terms of conversions, especially on the clinical use side, as we talk through this today. If we move on to the next slide, we have our second poll question. So which of the following do you think can be the alternative use of your hotel properties? Housing COVID-19 crisis fighters, care for non-critical, non-COVID-19 patients, non-isolation, and care for COVID-19 patients with mild symptoms where there would be isolation cases. All right, and we have a great mix here of how we think hotel properties will be used in the fight against COVID-19. So 37% of you said housing COVID-19 crisis fighters would be the main use of hotel properties. But interestingly, almost 2/3 say that there will be clinical use cases for hotels. This is quite insightful. Here in the US, we saw most of the focus being on crisis fighters, but in India, what we're seeing is that hotels are actually being used to house patients as well. So we'll talk through that as we move forward. So if we go on to the next slide. So what kind of assistance can hotels provide? Now, all properties are created equal, and you have to have multiple consideration factors as you start to think about how your properties can be used. The first is location considerations. What is the proximity to healthcare providers, such as hotels, pharmacies, labs, and what is the ease of access to that property? You also need to think about property considerations. Do you have interior versus exterior corridors? The number of locations of elevators? What does your common space look like? Do you have a commercial kitchen for meal prep? What are your security access points? And what parking locations do you have as well? When you think about your rooms, think about the number of accessible rooms, the number of adjoining rooms, the number of single rooms and double rooms, and also the types of locking mechanisms on your rooms as well. And then there's other considerations as well. So what's the willingness to convert to a hospital specs? There's quite a bit that you need to do to convert, which we'll talk about momentarily. What's the ability for the staff workforce to support where required? What relationship do you have with third parties as well? And what HVAC capabilities are needed as you start to think about this? So we have our next polling question. In your opinion, what are the following are the greatest challenges for converting properties? Time to execution, time to execute the conversion, adequate funding to conduct conversion, training of hotel employees, hotel guest perception. All right, so the majority said hotel guest perception would be your main consideration and challenge for converting properties, followed by adequate funding to conduct the conversion, and then training of hotel employees. Seems like time to execute was not as much of a concern versus the other considerations. So we'll talk about that in a couple of slides. As we move forward, so as you start to think about preparing your site for operations, there's a few considerations that you need to think about. First is hotel leadership. You need to define a temporary leadership model, which includes both operations from the hotel side, but also healthcare professionals for the alternative clinical care sites. You need to assign roles and responsibilities of leadership across hotel, healthcare, and government where required. You also need to think about if you're, especially in use case one, where you're hosting healthcare workers, is what are the channels for accepting reservations for non-clinical alternative care sites? How are you going to manage those reservations? In terms of sleep rooms and rate definitions, you need to define the operational room types that you need. And you also need to determine the rates of those rooms if you are hosting healthcare workers. And then what is extremely important as well is what training is needed for hotel staff and what education or certification would be needed too. So you need to consider all these, and there's much greater detail in our playbook as well as you start to convert. Now I'll hand over to Adi to talk a little bit more about additional considerations. Adi, over to you.
Hi everyone, my name is Aditya. Happy to be speaking with you here. As Mr. Kale mentioned, I am from Oliver Wyman Chicago office, and I'm part of their health and life sciences practice. I'll talk through two different aspects following Scott's lead here. The first one is many of you responded, about 35% of you responded saying you will likely see your hotels being used to house COVID-19 crisis fighters. So we have a couple of thoughts here for you to think about as you are accommodating those individuals in your hotels. And what you're seeing here is a decision tree, right? I mean, of course, in certain parts of the world, that's not a necessity. So, you know, that's not the question here. In India, that might be a necessity. So how should you think about actually housing these crisis fighters in your hotels? And really, it comes down to two things. Do you want to actually host not only these healthcare workers, but also guests simultaneously in your hotels? Or do you want to actually have one versus the other, right? And if you host both of these individual groups of customers simultaneously, what you'll need to think about is how do you actually shift the physical attributes of the hotel to essentially separate the COVID-19 crisis fighters from the normal guests that are visiting your hotels. There may be just some discomfort for those guests to be actually sharing rooms or sharing hallways, things like that, with healthcare workers that are, you know, frequently exposed to COVID. So how do you actually divide your hotel to accommodate that area? How do you physically separate them? And then also think about what are some of the testing and operational protocols you'll have to put in place, whether it be at, you know, the front entrance, for example, if you're doing temperature scanning to ensure that, you know, the hotel, the healthcare providers that are walking into your hotel are adequately tested and on a frequent basis. And lastly, you'll want to think about how long do you actually want to be hosting these healthcare workers to figure out if those changes you're making to the physical spaces are temporary or permanent. The simpler solution may be to actually just house those healthcare workers if you have adequate demand and forgo guest bookings. But of course, I think there's a variety of commercial considerations you need to be thinking about there. Also, you need to be thinking about what are the implications to forward bookings and ultimately the economics of the hotel. It may be that the government might be willing to offset a lot of those costs and ensure viability of the hotel. And then the bigger thing is, you know, well, what does the transition back to the general public look like? What does the time frame look like? Things like that are certainly considerations you should be aware of. Some other things that, at least in the United States, hotels are thinking about is essentially, you know, what is good for the community? Well, is there an opportunity for the hotel to step up and, you know, show some goodwill and actually, you know, respond positively to the community and use that as essentially an engine to, you know, a marketing engine, more or less, right? So will customers react positively to hotels that are, you know, stepping forward and offering their services? We're seeing some cases of that in the US, and it's working relatively well. So those are some things you need to be thinking about, whether you're hosting healthcare workers or not. Definitely a lightweight lift compared to the next case. If you go to the next slide, Nathan. If your hotel is going to be used for clinical care of either isolation patients or non-isolation patients, of course, the complexity is far, far greater. I'll share with you at least some of the recommendations here more broadly that the World Health Organization and the United States Army Corps of Engineers have put together. I think many of these recommendations may be applicable to the India market. We'll talk about more specific recommendations for the India market later in the slide deck. But broadly, we're looking at converting facilities that are large. I think, you know, the idea of converting smaller facilities just leads to a lot of complexity. So the recommendation has been, you know, typically a facility that can at least accommodate 250 or more patients in the sleeping rooms have been targeted for conversions. And most of these facilities typically support, you know, for every single sleeping room, there's a bathroom, there's elevators and corridors that allow for wheelchair access, as well as a variety of clinical equipment. There's a robust wireless infrastructure and telecommunications infrastructure in place already. Fire, life safety systems are also in place. You know, many times standard in large hotels, but not necessarily available in smaller hotels. The other things we also are thinking about, when targeting facilities for conversion, it's other things like how close is the facility to an actual hospital? That actually becomes a fairly critical consideration if we're thinking about housing COVID isolation patients. There's a variety of ICU equipment that might be needed that you're not going to shift over to the hotel, but you might want to actually get it from a proximal hospital. And so there's some of those aspects as well. And then within the hotel itself, the common areas are going to require some engineering changes. Think about converting some of the rooms into places where the staff can work, where supplies can be housed, where labs or blood draws can be conducted, where laundry and other things can be processed. So there's a variety of other common areas that your hotel may not have today that will need to be essentially converted to accommodate these clinical changes. I mean, in some ways, you're building a really makeshift hospital. So that needs to happen. You'll also need to think about installing pressure monitoring systems that isolate the contained side with the non-contained side. And so there's a bit of a structural change there as well. But there are many things you could reuse. You could reuse a lot of the furniture. You can reuse most of the kitchen dining services, the CCTV services, a variety of those things. So you can reuse that. Some newer things you might have to bring in are things like command center technology. We're seeing a lot of increased use of that in COVID-19 patients, especially given a lot of the physicians are doing telecommunications with their patients. So having like access to video cameras in rooms and being able to actually monitor that through command center technology is helpful. You'll probably have to install hand wash stations, signage, things like that for just providers to maintain hygiene. In the sleeping rooms themselves, there's a variety of equipment you'll probably also need to install. And, depending on your partnership with the government or a local hospital, you may be able to source these items from them. But it's a variety of standard things that you'd see in a typical hospital room, whether it be IV pumps or, just workstations for the provider or places where providers can dispense linens and sharps and gloves and things like that, infectious waste. So those are some of the considerations you'll have to actually think about if housing COVID-19 workers. As you can see, it's quite a bit more complex than just housing the doctors and nursing staff. If you're going to put in clinical patients, it's going to be a significant effort, but perhaps necessary in your market. Next slide. One thing to think about too is, once you've actually housed these patients or the providers themselves, many of our clients are asking us, well, what does that post conversion look like? If through that long haul of suppression, there's going to be spikes and there's going to be drops in COVID-19 cases. So how should we think about reverting the hotel back to its original state and guests can come back? And it's a few things. You need to think about timing. One of the things is how long will the property actually stay vacated before you can reopen it to guests? Here, I mean, we've largely been following the 14-day rule, to ensure that all aspects of COVID-19 are potentially eliminated. But that might be longer too, depending on your local government rules. The cleaning protocols have to be fairly extensive, probably quite more significant than the typical hotel cleaning protocols. And we do recommend getting some sort of a certification from a governing authority saying that the cleaning has been done to their standards, only because that will also protect you from liability and also ensure guests that, of safety. You'll have to think about converting those physical spaces back into hotel spaces, return any sort of equipment that you may have borrowed from a local hospital. And most importantly, it's communication, not only to your employees, but also to your customers that, your hotel is no longer, it's back to normal operations. Everything's been cleaned, everything's been certified. And, there's a lot of communication that needs to be done to ensure guest safety when you're ready to reopen. So those are some of the things to think about as you're going down this journey.
So Mr. Kale, over to you.
Yeah, thank you, Scott and Adi. It was really great insight, and especially from decision-taking consideration. It will really help. I request all the attendees. I think Oliver Wyman has published a very interesting playbook, Hospital COVID-19 Response Playbook, which you can download from their website, and it's really a great insight. With this, I now invite for next session Andrew Snedden and Greg Rodway to cover the aspects on risk assessment and hierarchy of controls. To introduce Andrew, Andrew is MRC Workforce Strategies Consultant for past 28 years and is having more than 40 years of health and safety experience. His primary industry focus is healthcare with all types of clients throughout US, including healthcare system, teaching hospitals, ambulatory care centers, senior living, nursing homes, behavioral health. Also, he works exclusively with hospitality clients with both full service and limited service hotels in US. With him, we have Greg Rodway. Greg Rodway is an workforce strategies consultant with over 30 years of commercial experience. Originally a healthcare professional, he transferred to consulting and has supported clients in the for-profit, non-for-profit, and government sectors across 6 continents. Most recently, he has been convener of Workforce Strategies COVID-19 Task Force and editor of MARCH, Returning People to the Workplace Safety, a practical guide for managing COVID-19. Over to you, Andrew and Greg.
Thank you. This is Drew Snedden, and I am joined with Greg Rodway here as a colleague, and we'll start our session on risk assessment and hierarchy of controls with a poll question. So the question is, have you assessed your readiness to convert your hotel operations to an alternate care site? Yes or no? Do we have the responses? Well, there you are. 50% of everyone has responded yes, they've done some type of readiness, but half have not. And I'll tell you, here in the US, as these businesses are starting to reopen, as Scott and Adi mentioned earlier, we're seeing that safety is one of those critical questions that are being considered by all types of industries, including our hospitality hotel clients. And assessing their readiness to reopen and return workers back to the job site is one of the pressing questions. And they're developing plans. The plans are based on federal occupational safety and health guidelines, as well as best practices that the US CDC and World Health Organization have put in place. And Marsh, we've put together a playbook. Greg Rodway was instrumental in putting that in place. And it outlines a number of steps that organizations, all different types of businesses, need to consider in reopening their business. One of the key concepts in the playbook is managing the change that's going to be taking place. We just heard, again, Scott and Adi talk about the hotel conversion to a hospital and the amount of potential physical changes in the work environment. And today we're going to talk about 4 steps. My focus is primarily on employee worker health and safety considerations, as opposed to that physical facility. But the 4 steps in the process: first, hey, let's identify what changes are taking place. Let's recognize the hazards associated with those changes, assess the risks, and then, consider the controls that are in place. So as we get started, here in the US, we had that initial phase in the pandemic, and the virus went undetected. We had tremendous transmission in different areas of the country, exponential growth in cases, and the result was hospitalizations and serious cases that really exceeded the capacity, the ICU capabilities of our hospitals. And so we ended up with these government and healthcare system partnerships that resulted in that bottom left picture on the slide. That's New York's Central Park, and the US Army Corps of Engineers. They stood up a mobile medical service unit there on that site because of the overwhelming cases in New York City. The picture on the right is a typical front desk at a hotel. And you can already see the changes that are taking place with disinfectants, physical distancing, people wearing face masks, and so forth. The US hotel industry, with travel being reduced, tourism being reduced, low occupancy rates. So there was certainly a need for filling those hotels. And part of that opportunity was to consider hotels as alternate care sites. They could be used for just triage of individuals, reduce some of the overcrowding at emergency rooms and hospitals, used for isolation for those individuals with mild COVID cases, and even for frontline hospital workers that wanted some respite from their work environment. Next slide.
Next slide.
Should we move on to the next slide?
Maybe Drew, do you want to just to speak to the points in the next slide and get it moving forward?
I will, and we want to talk about what is that new normal that all different types of industries are going through now. They need to put in place workplace practices, as a result of the coronavirus. The emphasis here is really on personal hygiene, hand washing, and just, covering when we have a cough. Physical distancing, we look at that 6 foot 3 meters as key as much as we can within the work environment. Enhanced cleaning and disinfection. Certainly all those high touch areas in a hotel need to be considered. And then HR policies need to be reviewed as well. How do we address ill workers, understanding just the symptoms for COVID? Hotels aren't any different. Hotel workers are looking more and more like healthcare workers in the amount of physical personal protective equipment that they're wearing. It's become standard practice to be wearing some type of face mask, let alone eye protection.
That's the one.
I think we're back to the slide.
Yep. Very good, thank you.
So it is. These hotel workers, as you go through your conversion, you're going to determine, what level of COVID exposure you might have within your facility. And that is going to increase the risk to workers, employees in those areas. What's really important is defining roles and responsibilities that partnership, the hotel operator, the healthcare provider, who's going to be doing what, and really working together to develop a comprehensive safety plan for the overall site. And we can go to the next slide now. So we have another poll question. So, converting hotel operations to an alternate care site will increase worker injury and illness risk. What is your opinion? Do you strongly agree, neither, agree or disagree, or strongly disagree to our statement? Give you a few minutes. Okay, I think we're ready for the results. Okay, 44% do agree that it is going to increase that risk, and strongly is 22. So, almost 2/3 of everyone does believe it will have some type of impact. Great. Well, when I think of the risk to hotel workers, for at least COVID-19 infection, here in the US, we look at it as a low risk for those in the back of the house without any guest-facing responsibilities. And those at the front desk, those who are interacting with guests, probably have that moderate risk. On the healthcare side, certainly those healthcare workers that are working with infected COVID patients, they're at high to very high risk. And those ancillary workers that are providing environmental service, cleaning, food service, they're probably still at the moderate risk level. So this conversion potentially is going to make a change. So we want to really look at what are those new hazards that are going to be created as a result of whatever option you've selected. We say the first is, let's review those operations. And this should be the hotel operator plus whoever is that medical provider working together, identify those existing activities that are, and the new activities, what changes are occurring. The slide here is showing just a typical hotel facility, the building with the surrounding parking lot. And what some of these physical changes might be just to the facility. And think first of security. Perimeter fencing goes up around the facility. We've got screening for the patient drop-off area. No guests are probably going to be allowed within the new facility, depending on that level of COVID patients. What hazards are a result of that? We have new materials that we're going to be introducing into the hotel. We have medical gases, oxygen, nitrogen oxide, probably compressed gas cylinders. Where are we going to store those? We have medical waste that's going to be generated. We have biohazardous red bag waste. We have sharps and needles disposal that needs to be stored on the premises. And people need to be involved in disposing of those materials. Then all the medical equipment that's going to be needed, all that PPE that we saw on the healthcare workers, let alone the hospital workers. That's combustible material, but it needs to be stored on site. Things such as a hand wash disinfectant that's alcohol based is a new potential item that could be stored in quantities. We're introducing medical equipment into these new patient guest rooms. And with that, we probably need additional emergency generators that are solely dedicated to medical equipment within the facility. We have the HVAC system, negative pressure for a COVID patient room is going to be critical to separate our hot areas from our clean areas within the facility. Infection control, one of the major changes that's going to take place. Who's going to be providing the cleaning of COVID patient rooms? Is it hotel workers? If so, additional training certainly going to be needed. Will the medical provider have their own environmental health service employees who have that training be involved? And will we have all the personal protective equipment needs? With all of these changes come additional hazards. And so the next slide, Nitin. What we're suggesting is assess those risks. When we have these new hazards, consider what's the frequency of that exposure? Is it highly unlikely, or is it highly very probable that we'll have it? And then what could that result be? All the way from slight, minor to a catastrophic type of injury or even fatalities. I wanted to take an example to give you, and what I see is one of the typical new features within a hotel, and now if it's going to be converted to a higher level of care for COVID patients, is just alcohol-based hand wash. What is that risk of injury or death from fire if we improperly handle large quantities of this alcohol-based hand wash into the hotel? And I feel it's likely that we're going to have substantial quantities, and if there's improper storage usage and we do have a fire, there certainly is a potential that it would be severe injuries to both workers as well as patients, could be even catastrophic. So, that's the process we want to consider, and you just never know when that pallet load of hand wash that has probably 48 cases, 1 gallon in each case, almost 200 gallons of flammable liquid that a hotel hasn't generally dealt with in the past. It comes to the loading dock, they need a place to store it. What's available is that unused portion under the stairwell, poorly ventilated area, it's a means of egress, and now we set up that situation for that catastrophic potential. These are the types of risks to consider. If we move to the next slide, as we identify a variety of risks from the medical gases, the hand wash, the emergency generators, the medical waste, think of the hierarchy of controls. And we always start at the top, the most effective: elimination. Can we physically remove that hazard from the workplace? With our sample or example of the hand wash, we could eliminate the need for substantial quantities if we can install just water and soap hand wash stations throughout the facility, in the public areas as well as those guest rooms. that would substantially reduce the need. Can we substitute, replace that hand wash with another? And really the alcohol-based 60% is considered the most effective in killing the coronavirus. That's probably not as good of an option here. But engineering controls isolate the people from the hazard. We have substantial quantities of the hand wash. We need to place them in an NFPA approved storage room. It has fire protection and all of the physical requirements to contain that specific hazard. Sprinklers, another key engineering control to have in place. And then what are the administrative controls? What work practices need to be adopted? We're going to have some new standard operating procedures for how we're going to handle and store all of the hand wash. We only want a one-day supply up in the patient care areas so that we're limiting the amount of flammable liquid from the hand wash. We also want to place our dispensers in areas that are out of emergency egress. And since it is a flammable liquid, we don't want to locate them, say, above an electrical source and an outlet within the facility. We're going to have large quantities. So we need standard operating procedures for a spill. What if it were to happen? And having said all that, what personal protective equipment is needed? Probably only in that major spill might we need some type of respirator for the flammable vapors that would result from a major spill. Those are the 4 steps that are really critical for each of the hotel operations to consider as you look at your conversion. Thank you.
Thank you.
Thank you, sir. I think it was really good insight. We started with decision process and then we looked at risk assessment. And with this, I will request my colleague Nitin to take our next section, on which he will talk about managing this particular transformation. Nitin is a chemical engineer with 14 plus years of experience in property loss control and life safety. He has been with Marsh since 6 years and responsible for providing risk consulting and workplace safety services. Nitin has worked closely on workplace safety and fire life safety consulting assignments with leading names in consulting, financial, warehousing, and hospitality industries. Nitin is certified fire protection specialist from NFPA. He has also completed OSHA's 18001 lead auditor certification. Over to you, Nitin. Nitin? Nitin, can you hear us?
Thank you, Mr. Khalid, and good evening to all. Am I audible?
Yes. Please go ahead.
All right. So let's continue the session with India-specific statistics. As we are speaking, about 600 educational institutions have been converted into quarantine centers. These are essentially universities, colleges, and hostels. And there are big names into it, like IIT Mumbai, IIT Shillong, some Kendriya Vidyalaya schools also have been converted. In addition to that, Ministry of Skill Development have also come to the rescue, and they have offered their about 33 institutions and hostels to be converted into quarantine centers. And the conversion is not only limited to the educational institution or hostel, like some iconic places like in Mumbai, like BKC or Mahalakshmi schools also have been converted. If we want to talk specifically about hospitality industry, Delhi, about 10 hotels are already planned to be converted to temporary hospital in connection with the local hospitals which are running there. There are plans for a couple more hospitals to run. In Mumbai, a couple of large properties are already hosting quarantine patients and medical staff and doctors. Other cities like Bangalore or Lucknow are not very far behind. I mean, there are properties which are already converted and a couple of properties are under talks to be converted into quarantine center. As we are speaking, the current number is 133, and what the number only represent the major cities what are displayed on the slide, but the other cities also follow the same statistics. And as the pandemic is increasing, the number will go higher. So before we continue to the next session, let's take our poll question number 6. Converting hotel operation to an alternate care site brings up its own life safety challenges. Do we strongly agree, either agree or disagree, or strongly disagree? Let's see how the audience is voting. Great. The poll results show that more than 63%, precisely 62% people say that the conversion brings up its own life safety challenges. And can you move to the next slide, please? And as we are speaking about life safety challenges, the governing code which needs to be talked about, or which first comes into the mind, is National Building Code of India. This code is basically the governing document issued by Government of India, and this was recently revised in 2016. Essentially, it classifies the occupancies or the buildings basis on their operation. The hospitals are classified as Group C1, and the hotels have been classified as Group A5 or A6 basis on their star rating. For this classification, they use 3-4 different parameters, starting from the construction, the occupancy load, the means of egresses, and the internal movement of the people. And if you look at those numbers on the slide, the requirement of hospital or care centers are much higher than any hotel occupancy. For example, stairway requirement for a hotel occupancy would be 10 mm wide per person, which increases to 50% more when we talk about hospital occupancy or a care center. It becomes 15 mm wide per person. While the travel distances to the exit remains the same, the fire compartment site increases from 750 square meter for a hotel to 1800 square meter for a care center or a hospital. So essentially, can we move to the next slide? So essentially what we see is when we are transiting, there are certain additional requirement comes into the picture. And apart from that comparison, there are specific requirements also. For example, when we are talking about exits or exit doors, the code says that the doors in the hotel should have a panic bars for all the exits. The hospital requirement becomes a little stringent. They say that this door should be self-closing and also should have electromagnetic hold open devices. So essentially the door needs to be open for ease of patient or any occupant movement. And if then whenever there is a fire or a fire alarm, the door would automatically close, creating a compartment. If we talk about flammable liquids, the hotel says that the flammable liquid needs to be handled only in sealed containers, and the storage area should have at least 2 hours of fire-rated construction. When we talk about hospitals or care centers, the requirement becomes a little higher. They say that a maximum of 3 liters of flammable liquids can be held in a floor plate area of 10 square meter. And in hospital occupancies or care center occupancies, we cannot have ignitable liquid or flammable liquid storage on the basement floor, while in hotel occupancy, we can have that. Can we move to the next slide, please? While we are housing the patients, the occupants who needed medical attention, the requirement also changes there. People who are incapable of self-preservation, in a simple language, those who are bedridden, should be housed up to 30 meters of height. This is basically for ease of horizontal evacuation, and other patients can be housed between the building height of 30 to 45 meters. And the restriction is there up to 45 meters because as per the local code, the hospital occupancy or care centers are restricted to the building height of 45 meters. We saw the compartmentation size of about 1800 square meter in previous slides. See, that is because in a hospital or a care center occupancy, if a fire happens, it is not always possible to evacuate all the people at the same time. So the best possible way to mitigate the fire and save the lives there is move the the patient, the people from the affected fire compartment to the adjoining compartment, and hence the requirement of larger compartment comes in, so that additional space of 3.5 square meter per person comes in, so that you can accommodate people, staff, visitors from adjoining compartment while you are fighting the fire in the next compartment. Requirements of exit widths, doorways also become higher when we are talking about care centers. For example, and that depends purely basis on the criticality of that area and number of people are accommodated there. For example, for ICU or for wards for more than 5 patients, the door width increases to 2 meters. The aisle width for patient movement area has increased 2.4 meter wide, and for other areas it is restricted to minimum of 1.5 meter. Next slide, please. Some more requirements where it says that the common path of travel still remains the same as 30 meters as the maximum, but the direct corridor is restricted to 6 meters. When we talk about hospital, the biomedical waste comes into the picture, and the code specifically talks about hazardous disposal, and that too into a safe area, and that the entire process needs to manage by a competent person. The hospital or care center occupancy, if they have a laboratory, the maximum allowable floor space is 10 square meter. If a bigger laboratory needs to be kind of set up, then the construction needs to be at least 2-hour fire rated construction. Plus, we cannot house it under the low basement's floors. Similarly, there is if we have stretchers, by virtue of its construction, by virtue of its load carrying capacities, we can use them as fire lifts, even if the care center do not have any additional fire lift. Can we move to the next slide, please? When we saw those requirements, or when we compare those requirements from hotel to hospitals or care centers, there are, no doubt the requirements are stringent. But then that brings a lot of questions in our mind that do we really need to do all of them? Is it really practical to do all of them? Because essentially, I'm a hotel occupancy, and after this pandemic is over, I need to switch back to my hotel operation. So do I really need to do that? And what would be the time to do time frame to complete all this recommendation if you want to, or if even if I want to choose? So what is the time frame? And the last and but important point is cost. Who would bear the cost? Because as Adi mentioned, probably the hotels are already running at low occupancy, and this additional cost of burden, who would bear? So these challenges, or answer to these challenges, come from the factors which influences the resumption post any evacuation or any fire incidents at the site. Can we move to the next slide, please? Let's take an example. God forbid, of a hotel. God forbid, if a fire happens or a fire emergency happens, and if we have to take out the people from the hotel, or as we say, the guests from the hotel, and you evacuate them, you take them out of the building. And now the next point is, if the hotel is non-operable or it is not safe to accommodate it by the guests, then you have to check with your other properties of the group, or maybe the neighboring hotels to accommodate your guests. The process will be time consuming, but relatively easy, rather than when we are talking about COVID patients, or for that matter, symptomatic or asymptomatic people. Because as a hotel is housing these people and news is in the market, even if you evacuate post a fire, it is difficult for you to have these people accommodated in any normal hotels, because these people will be really reluctant to host those people by virtue of their infrastructural issues. So that one thing which is really a governing factor post an emergency. Similarly, we know that the COVID-19 or the coronavirus is basically related to respiratory issues. It reduces the respiratory power, or it affects to the oxygen level in the blood. So it could happen that the patients or the occupants which are asymptomatic or symptomatic because of the fire, smoke, or hazardous fumes, there could be challenges, or there could be issues with their health, and we need to post resumption of operation, we need to check them. But in these cases, the fire could have affected your laboratories, your testing facilities. Now we land up in immediate need of testing, but we do not have equipment. That is another challenge. Third is the critical support services like electricity, power, air conditioning, telecommunication. For that matter, the critical gas like oxygen. I mean, oxygen is the most important factor when we are dealing with corona patients. So those loss of oxygen supply, access to the oxygen gas bank, the support system may get damaged, and then although you can see you are able to safely evacuate people, but then resuming the operation or having the test done or stabilizing the health of the people would be a challenge. The next factor could be as the patient's health can get affected, your staff gets health, medical staff health can also be get affected. So then after the shortage of medical, we may run shortage of staff also, because if less staff, then there'll be more time to stabilize the patient. The critical hard copy data like patient records or medicine supply, that can also get damaged or may become inaccessible if there is an evacuation or a fire happens pre-evacuation. So if you look at all these factors, and now we go back to those three buckets of time, practicality, and cost effectiveness. Now we have to compare these factors to your existing infrastructure and take a call saying that, okay, which are possible, which are not possible, which are practical, and which are time consuming, and which are immediately can be done, so that you can minimize the risk or minimize these factors for having an accident or incident in your facility, and you can control the incidents or control the fire in a smaller area, or limit the entire scene to a non-evacuation mode. With that, let's go to the next poll question. Great. What are the possible measures to be taken to bring down the fire and life safety risk after the conversion? Identifying potential ignition sources, ensuring adequacy and functioning of the fire life safety systems, making suitable changes to the buildings and infrastructures, and all of the above. Wow, almost 92% people say that all the factors what we have enlisted above are important. That's pretty much in sync with our next topic of discussion. Can you move to the next slide? So the four factors or the four parameters are listed. What you can see on the slide are the essential management program to be enforced or to be factored in when we are looking at this conversion. If we follow these four programs very religiously, then the situation will not lead to a bigger fire scene or a major evacuation mode. The first is hazard elimination process. Second one is functional testing of your FLS systems. Third one is egress management, and the fourth one is physical changes or the infrastructural changes at your site. Can we move to the next slide? So terms like hazard elimination, control of combustibles, or ignition source control are not new for hotel occupancies. They have dedicated fire safety team. They have a lot of fire safety manuals in place. A lot of trainings have been happening. But what happens here is when we convert the hotel to a hospital or a care center activity, the combustible gets added as the medical waste and the PP. So where to store, how to dispose them, that brings an additional risk of combustible, and that needs to be looked upon when we talk about control of combustibles. When we look at ignition sources, the new electrical equipment gets added. Flammable liquids like sanitizers, alcohol-based cleaning agents comes into the picture. Gas cylinders, flammable gases comes into the picture. So when the guidelines are reviewed, then these factors also needs to be incorporated. Egress routes like hotel, typically the fire safety team of hotel manages the egress route very efficiently, but the factors needs to be kept in mind as they need to be always free from obstruction, and plus we may have to convert them into the self-closing door and the held open devices as we spoke earlier. Inspection, testing, and maintenance program would play a major important role in keeping your fire life safety system in auto mode so that they would function when they are supposed to function. The next important factor is functional testing of fire life safety system. So even if you have an AMC or even if you have an internal team to service or to do inspection or maintenance of your fire life safety system like detection system or fire alarm system, it should be checked for their actual performance. I mean, trust me, we have been doing audit for a lot of commercial buildings, and though the records on the paper show very good that all the systems are working fine, when we actually go for a functional testing and we try and test the smoke detector activation can get as delayed at 5 minutes to 7 minutes. The emergency light starts for 5 minutes, but then it just goes off. When on the contrary, when it's supposed to run at least for 90 minutes for any commercial building or a hotel occupancy. Same case can happen with smoke control or staircase pressurization system. The fan just starts, but it is not able to extract the smoke, or it is not able to pressurize the staircase. And then the whole intent of putting that infrastructure in place is get jeopardized. And especially when we are handling people which need additional medical attention and additional resources to manage their egress. Can we move to the next slide? And the third and most important factor is egress management. Again, hotels, yes, I agree to an extent that the egress management is handled in a better way in hotel occupancy in comparison to a lot of other occupancies, because hotels would have a dedicated fire life safety manager, they will have first aid team, they will have fire responders, all that stuff. But now, one thing we have to keep in mind that the people we are handling need medical assistance. So in our decision-making team or in our incident commander team, we need to include the medical staff also. The clear-cut decision needs to be taken that whether we really post a fire incident, whether we really need to go into a full evacuation or partial evacuation with fire compartmentalization and moving the patients or other people into certain compartment will serve the purpose. When we want to move the people, how the movement will be done? Do we have dedicated people for moving the patient? Do we have dedicated people, adequate infrastructure to moving the staff? All that thing needs to be really thought about when we talk about egress management in a care center. We also need to think about staging area, what equipment we have, how many more equipment we need, how we transfer the critical equipment to a safer zone, so that whenever we want to do the testing afterwards, after we resume the operation, how best we can do it. And it all boils down to clearly laying out the roles and responsibilities. The clearer they are, it is the roles and responsibilities will be distributed to individual people, and they can act accordingly. Another important factor which we can think of is transportation. You may in all probability have to move after evacuation, move the people into ambulances. So at the max, ambulance can house 2 or 3 patients depending upon the medical condition of theirs. So just imagine if you are hosting 200 to 50 occupants which need medical assistance, how many vehicles we need on standby to take care of the situation post and fire incidents or an evacuation thing. It is very important to track the evacuated people also, because there will be a lot of untrained people like visitors. There could be occupant, there could be symptomatic, asymptomatic people. Not everyone will come to the assembly areas, so tracking them in the facility would be a challenge. Easy solutions can be given, like for the occupants, we can provide banding, the wrist banding system, color coding like green, yellow, red, so that the green can be for the people who can move on their own. Yellow could be for the people who are with limited mobility, and red are basically those who cannot move and need real assistance. So once banding is done, the evacuation managers or the fire team can easily identify these people and evacuate them out safely. Restoration of services should also be seen hand in hand when we talk about egress management, because as I have said earlier, we need to have those services intact, or rather resume as soon as possible after the any incidents happening in the facility. All the hotels have their own corporate life and fire safety standards. Those also need to be followed in conjunction with the code requirement or the requirement outlined here. The next point is training and practices. Basically, whatever the points are outlined here, the hotel staff as well as the medical responders needs to be trained in all these aspects, so that their responsibility are clear in their mind and the situation can be handled in more better way. And practice, yes, more and more practice when we do, more challenges will surface, more problems will surface, and the team is aware about that and vigilant about that, and the things can be managed better way. So along with the so if I want to summarize the session, along with the risk management matrix what Andrew has spoken about, hazard elimination, functional testing of fire life safety equipment, egress management, and the physical changes related to that will help in bringing down the fire and life safety risk in any occupancy, or while we are transiting from a hotel occupancy to a care center, or for that matter when we are operating a care center also. With that, I conclude my session and hand over to Mr. Kale for opening up the session for panel discussion. Thank you.
Thank you, Nitin. I think with this, we will shift to panel discussion. I think you had handled very nicely the local regulations and how it will be important to look at those, and while making this particular shift from hotel to hospital. Without giving any detailed introduction, yet because we have around 20 minutes from right now for panel discussion, and I really want to take maximum inputs from these four great speakers here. We have Harsh Thapar, Vice President, HKS India Design Consulting Private Limited. We have Sharad Garud, Deputy Head Engineering, Sir HN Reliance Foundation Hospital. We have Prabodh Purnabudh Kashyap, Director Fire Protection and Life Safety, Asia Pacific Merit International. And we have Nikhil Khakar, Senior Vice President and Practice Leader, Consulting Solutions for Marsh, India. I'll start with first with Mr. Garud. Mr. Garud, you have handled one of the very early project creating a dedicated COVID-19 hospital facility in Mumbai in the month of March 20. It was begun mid-March with some 250 beds. After 2 weeks of whirlwind work, as a collaboration between a couple of well-known hospital managements, state government, under the umbrella of the local municipal corporation. What are the important lessons learned and takeaways for the hospital project teams from this unique experience? Mr. Garud.
Yeah, so actually our goal was to set up the first dedicated COVID-19 isolation facility in coordination with the Seven Hills Hospital, in coordination with BMC at Seven Hills Hospital. So first we'll discuss the challenge, what we faced the challenge. Actually we started the project on 17th March, and 4 to 5 days it was okay because we got the lots of support from the vendors. And if you see the lockdown announced on 21st of March. So we faced so many challenges, like to manage the logistic for all the staff, site staff, contractors, all the vendors, and arrange the vehicle in coordination with permission with the government and BMC permission for that we required. Then vendor material movements and deliveries, that is more important. Like we required, as per the CDC guidelines, we required the HEPA filters plus UV light. We have to manufacture that, and we have to like movements and deliveries for that we require the permission from the police and BMC department. That's another challenge we face. And third one is like to arrange the breakfast, lunch, and dinner for all the contractor staffs and all the medical staffs also over there. So this is in the first phase we faced this challenge, and second phase, in first phase we have completed 100 beds, and second phase started in 1st of April, and that time COVID patients already admitted over there. So major challenge over there, like we have to work, all people knows the COVID patient is admitted over there, and major challenge to like screen all the employees, sanitization and all these things. Then convincing the vendor to do the work at site, continue to work at site. That was a major challenge we face actually over there. And like as CDC guidelines says, we have to maintain the like negative pressure, and we have to convert isolation ICU positive into negative. That was major challenge. We have to maintain the negative pressure 2.5 Pascal, then number of air changes that approximately 12 numbers, and exhaust as we have used the HEPA filter for that. That was a major challenge. And apart from that, when third phase start, and we have to like manage the routine complaints, then the medical waste management, housekeeping, all these things in the running. You can see there, you can see that. And major learning, if you see that whenever you see any hospital, any hotel, there are so many redundancies are available, like N+1. So learning, yes, redundancy is very important. Like we are preparing the risk matrix, disaster management plan. That is very, very important. I learned, yes, risk matrix, availability of source, redundancy is very important. In case of like DG fail, in case of power fail, DG should be available. Okay, like transformer, you should always redundancy should be available. UPS, DG set. So we learn redundancy is more important, and N+2 redundancy is very, very important for this critical operation. And if you see the building management system, because in this COVID scenario, suppose I want to increase or decrease temperature, so no need to enter that premises like in the ICU and all these things. So building with the help of building management system, we can increase and decrease temperature. And suppose any breaker trip like energy networking management system, so we'll get the SMS on the mobile. So we'll exactly know where is the problem. That is more critical, and we learn about this. This is learning.
Great. Great. Thank you so much. I think with this, I'll request Mr. Purnavud Kashyap that with the start of this current pandemic situation, Merit had launched immediately Global Cleanliness Council to promote higher standards of cleanliness in the age of COVID-19. This included rollout of enhanced technology to help counter virus spread, and this new multi-program platform details increased safety measures for guests and associates. Purnaji, can you please share with us your experience while executing this holistic approach on overall safety aspects?
Sure, sure. First of all, thank you for having me here, and good afternoon, good evening to everyone. So I think, Mr. Kale, just coming to your question, there was a three-phase program we rolled out in Marriott International globally, starting with the US hotels and then carrying over to Asia Pacific and Europe. Essentially, the first phase kicked off in May, where it was more of a study to get a mind shift change on cleanliness for our hotel associates, hotel staff, right? That involved training them to think beyond the levels of cleanliness that they were currently thinking, right? That was, phase one was, I would call it an education phase. Phase two was detailed protocols after they've been educated to think about cleanliness from the point of view of a virus scenario, right? That was phase two. So phase one is training. Phase two is getting the protocols in place for enhanced cleanliness. And phase three was we actually started deploying those levels of cleanliness. So phase three included using electrostatic sprayers in different parts of the hotel, mainly the areas you would have people often touching. Then our guest-facing assets, that is our front office staff, our staff in F&B areas would have an enhanced level of, I would say, distancing from the guests that they were interacting without actually, compromising on the experience for the guests. The third way of kind of building awareness for the guests as well is having in-room videos, and then kind of having cleanliness champions across hotels, where they would actually, there would be a designated person who would kind of oversee this process as at a hotel level. Now, essentially, this was a three-part program that was rolled out at the hotel level. This actually had two objectives. One is have higher levels of safety for guests in hotels, right? Whoever was coming in during this pandemic. For the second reason, or the second objective of this whole exercise was actually trying to prepare ourselves for a scenario where we would have to house either people who were quarantined, or guests who were actually asymptomatic, mildly symptomatic, possible COVID-19 patients, or in some extreme cases go one step beyond that, right? When jurisdictions, cities actually asked us to do that. So that is kind of the commitment to clean initiative that you refer to. So hopefully that gave you like a glimpse of what we were trying to do across the 3 months, May, June, and July.
Thank you. Harsh, I would like to ask you, HKS being very active in creation of hospitality assets as well as the healthcare facilities, how is design process, spatial design connected with infection spread and control within multiple building types? How you manage that?
Yeah. Hi, everybody. And firstly, thanks to Marsh for inviting me to share my views. And I think it's a very pertinent question. I just want to set the context that, I'm an architect. I work at HKS, which is an international design firm. And, we have a lot of experience in medical architecture as well as hospitality, as you mentioned. And, over the last few months as COVID has emerged, one of our internal efforts has been to leverage and kind of, connect all that data and internal knowledge into kind of, information power, let me call it, right, to kind of inform our projects, to reboot buildings, to help our clients, right? And what we've done is we've built a framework to evaluate, health risks, especially associated with kind of spatial risk, right? And, we feel there's a lot of, impact that design can have on the situation. And so let me just kind of jump on to a few points, which might illustrate that, design has a role to play and, what we're thinking about it. So the first point I wanted to really convey is that there's a lot of study, being shared right now about how COVID infection risk is higher indoors than outdoors, right? There's a study you might have seen that, risk inside buildings is 4 times than outside. I recently saw a Japanese study which puts that number at 18 times. So, I mean, I think the point here is that there is definitely something, that could be done, inside, which is actually increasing the risk so that it actually risk goes down and that you design it better, right? So that's something, that's the domain where kind of designers, architects, interior designers really need to work. And for that, I would actually put forth a very kind of simple model that I found, proposed by Dr. Erin Bromage, right? Which he says that, successful infection is equal to exposure to virus into time, right? And I think if we kind of dive deeper into the question of, exposure, you will see insights what designers can do. So, I mean, I think quickly kind of, mentioning it, basically exposure is connected to activity. That means, if I talk softly, I mean, I'm releasing a few particles. If I'm really lecturing or singing or, going to a gym, I'm releasing a lot of, kind of particles. So, so we need to connect activity to the space, right? We need to understand what's happening in the space. The second thing is that, how are these particles once in the space being removed, right? How much time is really being taken? So that actually leads to the, kind of leads to the question that architects need to understand the volume of the space in which, these functions are happening, the ventilation rates, the pattern of air, fresh air distribution that's happening. And because infection also spreads through touch, right? Predominantly through touch, right? Cleaning of protocols are very important. And materiality of, kind of dirty surfaces is very important. And all of this kind of connects to the fact that your exposure can be high or low in any building of any type, depending on its kind of arrangement and layout. So you may be either close to an infection source or you may be far. That means, intelligent layouts and intelligent planning are really, really essential to the whole game. And somewhere in this whole picture is also the question of human behavior. And I think architects need to kind of understand that, people will behave in certain ways in certain spaces. For example, masks reduce risk, reduce exposure, but not everybody wears them all the time, right? So what's the impact of that, on the kind of safety protocols that you put in the space, right? So that's the first factor, right? And I'm going to quickly jump into the second one, which is going to be very fast, is the factor of time. How much time do you get exposed, to the virus, kind of, or the infection source? And I think that all connects to the fact that whether the activity happening in the space is essential. Can you kind of reduce the time? Can you optimize the process? Can you even eliminate the activity totally? So, we've been kind of looking at with our clients whether certain activities can be either done remotely, can be removed, can be done differently. And, what I'm hinting at is that high risk activities should definitely not be done in high risk spaces, right? So if you're kind of singing, lecturing, probably it's better kind of doing it outdoors than an inside kind of air conditioned space. And, the last point kind of I want to make is that there is no single idea that will, kind of decrease risk. So what all of us together, it's going to be very collaborative, and interdisciplinary, definitely. We have to all come together to put together a system of steps, right? And design is, of course, also adding to that system. That would, in the end, reduce the risk of the spaces.
Thank you, Harsh. With this, I'll shift to Nikhil. As a risk management professional, if you have to pick one thing that you would recommend to the hotel management, and any resource challenge, you force it to work on that particular area, Nikhil.
So good evening all, and thank you for making up for this session. Now to answer Mr. Abasaheb Sky's question, I think all of you said that yes, life and safety is a challenge when it comes to changing from hotel to hospital. And Nitin gave you some numbers in terms of what are the specific requirements when it comes to egress management, right from the door width, the staircase width, and the specific issues when it comes to evacuation of people, more so when they are COVID patients. So, but that stage only comes when there is an event, and that event happens when there is a fire. So for me, I think the first and foremost thing would be for ignition source control, and probably I would extend that by saying control of combustibles. Management of combustible control becomes very, very important, because if we can avoid that, then the chances of fire gets reduced. So I think these two, I would say, are the first and foremost things. Coming to the second part of your question, which is the resources. I think Mr. Kashyap would agree that when it comes to hotels, they are the risk management framework, and more so in a fire life safety management, is pretty robust. We have seen in many hotels we have visited. So in terms of resources, I don't think that is a concern when it comes to fire and life safety. It is just that the additional training which would be required for doing an effective egress vis-a-vis a normal patient, a normal guest, to patients like COVID related patients. I mean, Mr. Kashyap would agree on my statement here.
Great. So there is one question for Mr. Kashyap here from Shruti Jalodia. What are the measures taken to ensure air safety apart from cleaning drive for guests and staff? Was there replacement of HVAC filters or get more fresh air?
All right. Okay. So, I mean, I think just one thing I want to make it, kind of clear is that I head the fire and life safety division for Marriott in Asia Pacific. However, I do have insights into actual hotel engineering and facility management. I believe there was a special initiative program undertaken by our engineering teams as well, in parallel with the safety initiatives that I spoke about, which we call commitment to clean, right? Obviously, clean air, fresh air it was a part of that process. I can't specifically tell you what was the frequency of replacement of air filters before to what it is now. But all that I can tell you for sure is that there were enhanced initiatives taken by engineering across the region, across the Asia Pacific region, obviously of which India is a part of, South Asia is a part, which definitely involved improvement in air quality. Obviously, I am not aware of the specifics. They are done at a regional level, at more of an area level, and also at a hotel level. But there are policies that were put into place by our engineering team, which ensured cleaner air, I would say, as a part of our overall, enhanced SOPs for, I would say, the pandemic scenarios.
Okay, I think just to continue over that, Mr. Kashyap, is there any Marriott hotel anywhere globally or in India which has been converted into any hospital facility or similar healthcare unit? And what are the takeaways in general? You're on mute, Mr. Kashyap. You're on mute.
Sorry. Okay. What I was trying to say, Mr. Kale, and to everyone was, I'm just trying to I'll start off by giving you a few examples of hotels, and then I will kind of try to answer your second part of your question. So the answer to the first part of your question is, there are 2 or 3 levels of occupancy that are happening here. The first level is just quarantine centers. The second level is housing mildly symptomatic and asymptomatic patients. And the third level is full-fledged conversion to a hospital. Now, let me just start with India or South Asia, right? There have been various properties around the country, specifically properties close to the airport. As an example, the JW Marriott Sahar, which is close to the Mumbai airport. The JW AeroCity, which is close to the Delhi airport. That have been used as quarantine centers by the Aviation Authorities of India, the Airports Authority of India, as well as the government. So these quarantine centers house the guests who are flying in and are required to be quarantined for a period of 7 to 14 days, depending on how things go, right? That's number one, right? That's the first level. There's a second level, which is housing asymptomatic and mildly symptomatic patients. I believe this was happening for a few days in Lucknow, right? We have a Fairfield and a Renaissance in Lucknow. And I know that Delhi, the government of Delhi put a number of their hotels, number of our hotels, including other hotels in the city, on standby to serve as facilities, right? The third level is, actual hospital facilities, right? It's not happening in India, right? We don't have any full-fledged hospitals that I'm aware of in India, in our properties, but we do have two hotels that I would like to mention. One is a Marriott in Madrid that was converted for a period of time into a, I would say like a healthcare center, not a full-fledged hospital, but a level above the, the mildly asymptomatic conversion. The second property was the Marriott in Brooklyn Bridge in New York City. That was also, I believe, served as this kind of a healthcare facility for a few days. However, I believe is still on standby for a larger enhanced healthcare protocol in New York City. I'm sure there are other hotels in the US, but I just wanted to kind of give you examples of, large cities in Europe and in the US. That's the answer to the first part of the question. The answer to the second part of the question is, I strongly believe, I think this is kind of, following whatever your speakers have spoken, I think. Egress management, handling of hazardous material, and storage of flammable liquids. These are the three aspects of fire and life safety that hotels greatly differ from hospitals, right? We are not trained to defend in place, which is horizontal evacuation from one smoke zone to another. We are trained to evacuate guests out of the hotel. We are not trained to defend them in place. That is a big departure from our, emergency response protocols. The second departure or the second enhancement that we are not typically trained for, and we don't train our associates or employees for, is handling any quantity of flammable liquids, right? We avoid flammable liquids in our hotels, right? We don't store any propane. Our LPG storage is typically outdoors with sprinkler protection, So handling of flammable liquids of whatever quantity there is, right, is a challenge for our staff, right? Which is no two ways about it. The third thing is handling of any hazardous medical waste disposal, right? We are not trained to do medical waste disposal. This is not something that you can, do a crash course on, right? So I believe, these three, these three aspects are challenges that are significant, which I think, limit hospitality occupancies in general to serve as any care of to serve as any way of a comprehensive health center for any given period of time that is larger than maybe a few days or a couple of months. I think that kind of is very clear that any asymptomatic patient or mildly symptomatic patient that ends up becoming symptomatic has to be treated in a full-fledged hospital, right? Hotels are not the place to do it. I think, as I said, at best we can be that bridge between, not housing them in a hospital at all and finding no bed space to housing them in a full-fledged hospital. That's kind of the role we are playing currently in a few of our hotels.
Great. Thank you, Mr. Kashyap. We have one question from audience. Mr. Nagendra Pratap Singh wants to ask this question. Niladri, can we unmute Mr. Nagendra Pratap Singh, please? Niladri?
Yeah, Mr. Singh, can you hear us? You can unmute yourself and talk to us.
Mr. Singh, you can unmute yourself. I think we'll just go ahead. I'll ask Mr. Thapar. I think recently HKS worked on a very interesting project in USA to convert an expo center to COVID-19 field hospital in 15 days. Designing and delivering projects of this nature, and that too at a fast pace, would be challenging. Any learnings you wish to share from it? What are your thoughts about now rapid conversion of hotels to COVID care centers like this? You're on mute, sir.
Thank you. Yeah. So yeah, I got the question. Thank you very much. I think before I start, really, I mean, I was, hearing some very interesting points from Kashyap and Mr. Kashyap, and I just wanted to react that, from our experience as well, I think, we designed, full-fledged hospital, which was, recently completed in Wuhan, right, where it all started. Okay. And we have, just designed, in April end, a rapid, kind of ACS project, which is the one being mentioned by Abba Sahib here, right, in Detroit. And I think there's a distinct difference between a full-fledged hospital and, kind of an emergency kind of setup that you create for. So I think that has to be understood. Anyways, going to, what you were saying, sir, is that, yes, I think in end of April, we completed a very kind of exciting project, which we're very proud of, which was done in collaboration with US Army Corps of Engineers. And this was, a field hospital rapidly created for 250 people near Detroit, a place called Novi. And, our, Detroit office worked on it actually, but I have some internal kind of insights, which I'm kind of sharing with you. I think one of the key things that, was important for this project was that the expo building that was selected very carefully, right? It was not just any expo building. I think it was kind of evaluated so that we find that it was easy for conversion rapidly. It had large 4 plates. It had built-in kind of life safety features, multiple exit entries, fire safety features, and very importantly, I think it had a proximity to Providence Hospital, which was the base hospital which connected and kind of sent non-critical care patients to this campus. So that was one aspect. And the other thing is this, that this project, was possible because very clear, kind of medical requirements were laid out by the state authorities right away on the first day. And I think such a thing can, so if you're trying to kind of convert any facility in India, I think that would be key, right? The second key thing, what I think we learned from it is that all the stakeholders must jump in on the table right away, right? Because if you want to build anything in 15 days, you pretty much design and build simultaneously, right? You don't kind of design, you don't have a design cycle and you have a building cycle. So this was, of course, a huge collaboration with, kind of city authorities, government health experts, designers, definitely a very important collaboration with our building contractor, right? Because everything was on the go. And in the end, lots of things were, based on our existing knowledge from all the hospitals, like hundreds of hospitals, over the 80 years that, my organization has done, right? Somewhere, it had an impact on, the sketches that were being made on site, right? And eventually it was converted into a Revit model. And, we kind of shared the Revit model. Everybody could interact on it. The technology was, kind of leveraged as well. But it was a very hands-on process. And at the end of it, we, built kind of facilities inside for 250 people, kind of segregated patient spaces, segregated nursing spaces, spaces for pharmacy, for, kind of toilet, showers, all designed to, the code and health requirements, that could be done in the time provided. And it all happened in 15 days. So very exciting. And I think, in this context, I mean, I would say that what we concluded, so we did a very interesting, kind of analysis also about, conversion of hotels, right, to, alternate care size. And this study, is available on our website for free. If you're interested, you can download it or reach out to me. And I think, what we concluded is broadly, it's quite an achievable concept, right? It's not like undoable. So if anybody is thinking that he really can't convert it, I think you can convert it, provided you're very clear about the kind of medical facility you need to provide in it, right? So it's not a full-fledged hospital. That will kind of make it more easy to achieve. If you wanted to do a full-fledged hospital, it's a slightly longer game, a much more detailed game, I would say. Yeah. And I think in the end, basically, the process would be to kind of take your existing plan and you would kind of, superimpose all the medical planning principles on it, right? And you would then evaluate what is possible, not possible. And, hospitals are such a, I would say, special, kind of a complex beast, I would call, that, there would definitely be certain compromises that will happen when you convert a kind of hotel building to that, right? But we need to be clear that can we manage those, during the operation phases, right? Can we reduce the risk? And, in the end, the message I really wanted to give was that, each hotel is pretty much unique. But, from the analysis, my research teams and, hotel, sector has been doing inside my company, we feel that full service hotels with, banquet facilities, convention facilities, and especially hotels which have space around them, right, in terms of ground space around them, are definitely well positioned to kind of, take on this opportunity.
Adopt this change. Great. So there are few questions from audience. We have one question from Mr. Sandeep Nalavade. He's from Hilton, Mumbai. Dear esteemed panelists, being hotel engineer, we are doing our best to reduce coronavirus exposure for occupants. Can you all advise on usage of ozone and UVC lights? How much it will be effective, as there are no guidelines available? I mean, Mr. Kashyap or Harsh or Mr. Garud, anyone likes to take up this?
I could react to it. I mean,
okay, please, Harsh. Yeah.
So I think it's an interesting question. I think it connects to the fact that, what I was saying, there would be multiple strategies and multiple technologies which will come to kind of decrease your risk, right? So toilets are especially high risk areas. And that is because they are spaces where, you would kind of touch a lot, and there would be also lots of aerosols created. So I have come across kind of certain new technology companies which are really kind of promoting ozone. So there'll be regular doses of ozone that will be kind of sent out, at regular intervals in the toilet spaces to clean them up, right? So I think there is potential in that technology. Ozone has been used for disinfection, and so has UV been used for disinfection in hospital settings. The only thing is, I find that UV is being sold for kind of ventilation systems as well, which I thought was a little bit of a stretch. Because, if you have air moving through a system, right, you're kind of bombarding it with UV, the amount of, the time interaction between UV and the air volume is very little. So I feel that would be of very little kind of, significance. However, and also UV will only be effective on the surfaces which it sees, right? So it's a light source, it's a ray. So that's my reaction.
Great. There are two questions for Mr. Kashyap, but I'll take one of it. There is a question from Chetana Shekhawat. Did you feel the need during conversion for low touch experiences when designing new hotels? As healthcare adopted telehealth rapidly, do you think hotels will need that shift as well?
Yeah, no, I think it's a really good question from Chetna. I believe we are moving towards, hotels, new hotel design especially, where we are going to see a revision in concept in general. So my team and I, we are tasked with opening new and safe hotels. So we have an architectural construction team. We call it the global design team, who we actually partner with to open, hotels across the Asia Pacific region. So they are tasked with designing the hotels, right? Or helping the architect meet brand standards. So I believe definitely these low touch experience introduction into the design processes is inevitable, because obviously the virus is not going to go away tomorrow. We are seeing a few protocols that are already being undertaken by our global design team, by our interior designers, where they've actually started coming up with models, coming up with brand immersion protocols, where they're actually having, for instance, a low touch reception design, built into the overall brand standard, right? This wasn't there before, right? So just as an example, like a screen, right? A screen which does not look ugly, right? Which does not look unwelcoming, but at the same time, it serves a purpose which protects our front house staff while interacting with the guest, and obviously it protects the guest from our front house staff as well, right? Obviously, but that, those kind of low touch experiences, I would say, built into the hotel design on new hotels in our brand standards are inevitable. I'm not talking just about Marriott. I'm sure my competitors are thinking the same way as well. In addition to that, digital check-in, hands-free check-in through mobile. I think that was already there in the market. That was already there in the general purview of our app experiences. But I believe people are going to our guests are going to start using it more and more. So I think it is obviously a low-touch experience from a design point of view, as well as guests checking into hotels, exploring new ways of actually reducing their touch themselves. So I think it's a combination of two. I'm sure hotels are going to go down that way.
Thank you, sir. So we have a limitation on time, but still we'll try to address a couple of questions. I'll like to ask Mr. Garud, what are the typical challenges while managing the patients, visitors, and skilled, unskilled staff while operating a COVID care facility? Would you like to comment, sir, with your experience now, current experience in Mumbai?
First of all, actually, people should know what is actually facility, because any hotel industry or it's like our hospital industry, rooms are same. If you see the HVAC system, everything is same. But what we did actually, we have converted, every room is having either positive or neutral. Like you can say in hospital and hotel, they are fan coil filter recirculating the air, right? So what we did, actually, we have installed the HEPA filter over there, and we have converted all this room into negative actually. If you see, we'll take example of 100 square feet area, that CFM, FCU CFM is 400 CFM. We are adding 10% fresh air. So 10%, you can say 50. So we have installed the 100 CFM double capacity CFM exhaust with the HEPA filter. That is more important. So what we did actually, we have made all the rooms are negative pressures. So whenever we have ensured that patient room, that air will not enter into corridor actually. Okay, that is more important factor. So anybody going to the corridor, so there will not be any infection to that people or maintenance team or any staff. So that we have ensured, and we have given training to the staff. But it is very difficult challenges, like we have to, like any complaint comes, so we have to again wear the PPE, then N95 mask. That was a major challenge. Like few places like ICUs where there is power tripping happens. So we have to, like, due to some short leakage current is happening, RCB tripping and all this, everywhere. It is a safety purpose. One complaint, like they are connecting the charger. So education is very important, very tough to like explain to, like new staff is coming, and again education is very important over there, and that's a major challenge.
Great, great. Thank you, sir. Thank you. I think we will take this last question, and this is for Harsh. Are there rules that all buildings can follow to safeguard their occupants, or is it better check each property individually to be have effective solution?
So I think, it's, as I said, it's both, right? I mean, there's definitely common wisdom, and a lot of the common wisdom is emerging from health guidelines that are coming from CDC or Ministry of Health, right? And they must be followed, right? I mean, I think that's common. But being an architect, I understand the nuances of a design, right? A certain corridor in a certain way actually either encourages you to go touchless, or encourages you to touch surfaces. It either encourages natural ventilation to happen in that or it doesn't, right? And like, for example, corridor spaces are really very important for hotels, I would say, to evaluate them carefully. So so my suggestion is, do follow all the guidelines, definitely. But if you can, please involve an expert and really kind of look at your floor plan very carefully, analyze it and analyze the risk and decrease it.
Great. I think thank you everyone for all the responses and detailed discussions what we had. We are already 6:47. So some of the questions have been answered live by Nitin. First of all, I thank you all the speakers and all the panelists for sparing their time today for this important discussion. We at Marsh, we thank you, all of you. I think we had good crowd from the fraternity. We thank you all the attendees who were there present for today's session. And with this, I declare this session as closed. Once again, thank you all of you. Please stay at home. Please stay safe. Thank you.
Thank you.
Thank you, everybody. Thank you very much.
Thank you.
Bye-bye.
Bye.
Bye now.